Thank you. So last CE of the month for the summer. Okay. Well, not the last one here, but so you won't see me again until September, so you'll get a little bit of a break. But today we're going to go through trauma, and Adam put this together. We're going to talk about general trauma assessment. We're going to talk about crush injuries, compartment syndrome, a little bit about the fluid resuscitation, and then I think that pretty much covers everything. As we're going through trauma, we have a tendency to think, oh, it's just trauma. It's pretty easy. It's basic. We give them an IV. We give them fluids. We get them to a hospital where surgery needs to be done. In reality, that's it. But we see throughout the state, through statistics, through where they collect a lot of the data, that we actually have a problem with trauma. Even when we see with our paramedic classes, trauma is not a strong area for a lot of students to go through. And it's just because we don't know. It's so difficult, it's so hard to go ahead and try and figure out what truly is going on. Obviously, if we have a gunshot wound and we have a big hole in the chest, that's pretty basic, that's pretty easy to understand. But when we have that blunt force trauma, there's so many different organs in the abdominal cavity, and for us to truly diagnose it, I mean, we don't have x-ray vision, we don't have ultrasounds on the ambulance yet, so we really can't, yet, I know. So we're going to kind of go through some of the signs and symptoms, kind of remind you today what about some of the different organs. Bottom line is when we're doing our assessments, we're taking care of the ABCs first, any life threats, and then following up with our assessment. We used to talk about the golden hour, meaning from the time the patient got hurt to the time that patient made it to the OR. It had to be an hour. However, we've gone ahead and changed things a little bit. We've actually talked about now in EMS the platinum 10 minutes. We try and limit your scene time down to about 10 minutes. Now, obviously, if you've got someone who's prolonged extrication or, moving somebody out of the house, that's impossible to go ahead and do, and it's unrealistic to ask you to do that. But we really want you guys to consider there's really only two patients we load and go with. One is a stroke and one is a trauma patient, because those patients we really can't do a whole lot on scene. They need to be somewhere where they can have surgery, be at an appropriate trauma facility for the most part. So as I go through this today, again, please forgive me as I skip through some of the slides. I didn't get a chance to remove a good portion of them, to be honest with you. Some of it, especially when we come to fluid resuscitation, doesn't have the most up-to-date information, and so I don't want to confuse you by putting a slide, having you read it, and then have something else come out of my mouth. So I'll just probably skip over some of those, and I'm sure you're not going to be too heartbroken for the most part. So dealing with our trauma patients, in order to really improve their ability to survive, we have to do a good assessment. One thing we've seen over the course of years, probably in the last 8 to 10 years, is that we don't touch our patients anymore as we assess them. We listen to them if they're able to tell us. We say, well, do you hurt anywhere else? Well, no, I don't. They've got this angulated ankle injury from a fall, but do you hurt anywhere else? Well, no, because the pain there is overwhelming. We don't actually go ahead and do a secondary assessment a lot of times to find any other injuries that might have occurred. So we're missing a lot. We don't expose patients like what we used to do. Take a look at the abdominal. We go through the clothes and say, okay, does it hurt here? No. But we don't expose the area to see that there's abrasions or any bruising that's starting to go ahead and appear. So in order to really truly treat patients, we need to do a good assessment, and that's where it all starts. Even before we get to the patient, as we arrive on scene of a car accident, obviously we talk about our scene safety, making sure the car is stabilized before we go ahead and go in, make sure nothing's going to catch on fire, make sure all airbags are deployed, or if they're not deployed yet, are they still charged? Are we still going to have a problem with those? And so those are types of things we're going to take care of first. We're also going to look at the mechanism of injury. How fast were they going? How much damage is done to the car? Is there star into the windshield? Is the steering wheel bent? Is there intrusion into the patient compartment? And again, that's before we get to the patient. So we can have a general idea. We can start putting together a scenario before we actually get to the patient and see what's going on with them. Which kind of goes into our index of suspicion. We see a bent steering wheel, we might be able to assume that they have chest trauma, they have abdominal trauma. We see starring in the windshield, we might be able to assume that they hit the windshield with their head. They have a head injury, they have a neck injury, facial trauma, something to that degree, based on what we're seeing with the mechanism of injury. And then we finally get to that general impression. We finally see the patient for the first time. What does that patient look like? Now, we can go through all of this in-depth stuff, but bottom line, let's keep it simple. Do they look sick or do they not look sick? Very simple. If they don't look sick, then we can maybe go ahead and do a little bit more of a focus exam compared to, oh, this patient really looks sick. Let's go ahead and rapidly extricate him. Let's do a rapid assessment and let's get him to the hospital as soon as we can. So here is just basically our overall trauma assessment. We start off with our scene survey. We do our primary or initial assessment, whatever you want to call it. It changes names every other year for the most part. But here's where we do our ABCs. Airway, breathing, circulation. Is it trauma or is it medical? If it's trauma, are they stable or unstable? If they're unstable, we do a rapid. If it's stable, we do a focused assessment. So we can start off, like I said, with the index of suspicion. Based on the injuries or based on the mechanism, kind of assume what might be going on. So that can lead us to focus a little bit more in depth on those areas. Look for any problems. Our general impression, again, do they look sick or do they not? What's going on with the patient? So here with this guy, okay, that's pretty overwhelming. We see that and it's like, holy crap. Where do we start? But we have to go back and start with the beginning. Airway, no breathing, no patient. The fact that he's got his post in places unknown is really irrelevant. No airway, no patient. No breathing, no patient. Take care of that first. Yes, this actually might kill him for the most part, but what's going to kill him faster is the fact that we've got to control that airway. Does he have a patent airway? Is he talking? Do we hear snoring respirations? If that's the case, yes, great. We have an airway. Is he breathing? We don't need to know that he's breathing 20 times a minute. All we need to know is it too fast or too slow? And go from there. Fix any life threats that may be. Maybe he has a tension pneumo. Maybe it's just as simple as us needing to put oxygen on him. And then we move on to our circulation. Do we see any abnormal bleeding or excessive bleeding? Obviously, internal bleeding with his leg, you can see that he's either lack of bleeding there, or blood flow, and he's bleeding into his belly. So when we start off with, we go through this scene size up. One thing I've started with my paramedic program this last year is that every time people would do an assessment, they do this whole thing, BSI, scene safe, number, and they go through this EMT vomit, I call it. The thing about it is that BSI changes. Your need for personal protective equipment changes throughout a call. And so, can you recognize that? I don't want them starting off with this BSI, scene safe, because really what is it other than just spewing a bunch of words? Do you recognize the need to change? Maybe from just gloves to putting on a face shield, to putting on goggles, to using a hazmat suit, and recognizing that. We also look at our mechanism of injury. How many patients do we have? And then do we need any additional resources? Now, what do we mean by additional resources? Well, do we need additional engine crews? Do we need police for traffic control? Do we need Con Ed for, electric or public works? Those are the type of additional resources. Maybe we even need a helicopter to go ahead and transport this patient to the appropriate facility. So we look at something and we've got to make the determination right away. Are we safe or are we not? Is the patient in any type of danger? Are we in any danger at that point? So after we formed our initial impression of the patient, we need to check for responsiveness. Now, a lot of people say, well, they're alert and oriented times 3, or they're alert and oriented times 4. To be very honest with you, I actually think that's ridiculous to use those, because I kind of always fall back on the term of someone who's been drinking. There's people out there that can put away the alcohol, they still know their name, where they're at, what's going on around them, but under no circumstances should they be making their own decisions. They're slurring their words, they're unsteady on their feet, you know, those types of things. So instead of using alert and oriented times 3, are they alert to my voice? Are they answering appropriately? Are they asking questions appropriately? You know, and is their behavior appropriate for the situation? Then if that is so, then we can determine that that patient is of sound mind. Again with the airway, is it open or not? If it's not open, we've got to fix it. We've got to do something right then and there to go ahead and correct the problem. Now, if you go back and you remember your whole algorithms, they talk about C-spine control right off the bat. You don't know how a patient ended up on the floor or any type of trauma. We take control of C-spine right off the bat. How have you guys been doing with the selective spinal immobilization? A lot better? Yeah, I mean, before we used to go ahead, everybody got C-collared and backboarded. Now we're giving you guys the opportunity to use your assessment skills and do what you feel is best for that patient. You know, don't put the patients in any undue, you know, pain, I guess is the better way for it. You can have someone go ahead and take C-spine at this point in time, but to put the collar on right then and there before you actually get through that assessment is probably not the best idea if you're going to go ahead and use a collar. You know, wait till you're getting ready to move the patient. Breathing, look, listen, and feel. Too fast or too slow. Again, I don't need to know that they're breathing 16 times a minute. Do I have unequal breath sounds? Do I have a possible tension pneumo? If so, I've got to fix that life threat now before I move on to the next step. Look at C. A lot of people go ahead and they feel a pulse, and they sit there and count it. Again, too fast or too slow. That's all we want to know. But there's more to the circulation than just checking a pulse. As you're feeling that pulse, what's their skin parameters like? Are they pale, cool, diaphoretic? Could they be getting shocky? Are they warm and dry and pink? Are they fine? Do they have good circulation? What's their cap refill? Now always remember with cap refill, they may not, if they're, you know, hypoperfusing, they might be slow, but if their hands are cold, if it's the middle of winter, they might be a little bit slow on their cap refill. Expose and examine. Go ahead and expose the areas. Take a look at the skin underneath. Cut clothes off if you have to. Actually palpate those areas. Make sure that there is no other damage or any other pain. Sure, they might say that there's no pain in their arm, but the minute you go ahead and palpate, they're like, ow, something hurts. And so you want to make sure that you're getting all injuries. We don't need to know that exact blood pressure, exact rate of respiratory or pulse at this point in time. It's very simple. If they have low blood pressure, if they have low heart rate, they're probably going to look sick. And we're going to treat them based on that. So in our primary, we're going to maybe take C-spine, we'll take control of C-spine, but we'll put the collar on after we do a good assessment. We're going to expose the patient. We're going to go ahead and correct any airway problems. I don't know why he has this in here because we have not used mesh trousers in moons, you know, so you can kind of strike that information. Starting IVs. Yes, a lot of these trauma victims do need fluid resuscitation, but we're going to talk about that here in a little bit when we talk about permissive hypotension. Don't sit there unseen and try and get an IV. You know, get them to the hospital where they need, where they can get the surgery. The other big thing is taking them to the appropriate facility, whether it's a level 1 or a level 2 trauma center that you want to go to. And then notifying the hospital early that, yeah, we have a level 1 trauma. We want to, what we're coming in with. Once we get to the secondary exam, getting a history can be very important. Now, not all of our trauma victims can give us accurate information. You know, we have to sometimes just go with what we know. But that information, the medications that they may be on, are important. You have someone who maybe takes Coumadin and they've taken a fall. Even if it's from a standing position and they conk their head, that could be significant. They may have a head bleed. You've got someone who's on a beta blocker. They might not actually show signs and symptoms of shock with that elevated heart rate. So understanding what medications are going to be important. Do our physical exam. We've taught you since beginning, day one, to do a head-to-toe assessment. Now, if our patient is unstable, we're going to do a rapid. And we'll quick 60 seconds head-to-toe assessment, fix any life threats at that point. When we look at a focused exam, we can kind of zero in on some of the injuries that a patient may have and then go back to the head to toe. But it just really depends. The big thing is for you guys, it doesn't matter how you do the assessment, as long as you're getting every area and making sure that you're assessing everything. So if we suspect a significant mechanism of injury, our patient looks sick, we're going to do that rapid. Spend a quick moment. We don't have to look everywhere. We don't have to look in the ears, the mouth at this point. We just want to go ahead and make sure we're looking, at the eyes, some of the more important things. Do they have carotid pulses? Do they have tenderness in the neck? Is the chest rise and fall? Is there pain in the abdomen? We put these darn mnemonics in here, DCAT, BTLS, TIC, which is a nice mnemonic, but bottom line is it abnormal or is it normal? Who's going to remember what all of those letters are? I mean, how many of you guys in here remember all those? A couple of you do.
No, we were never taught that. That's new.
Deformities, contusions, abrasions, punctures, burns, lacerations, swelling, tenderness, and instability, and crepitus. Got it?
Yeah. No.
You didn't have the tick?
Yeah.
They keep adding new ones. But bottom line, okay, so patient doesn't. And I listen to these students go, I'm looking for DCAT, BTLS, tick. And I'm like, all right. Bottom line is, we all know, does it look normal or is it abnormal? I look at this arm, and there's no bruising. There's no abnormal marks. This one's got cuts, lacerations. That's all I really need to know. The fact that I sit there and go through all these mnemonics is, to me, really irrelevant. Why make things more difficult than it has to be? However, Alejandro, for you, no DCAT, BTLS, tick, okay? So, now, if there's no significant mechanism of injury, we can spend a little bit more time on scene. We can focus a little bit more on the assessment. We can look for those localized injuries. Okay? We're still going to use our, is it normal or is it abnormal? Do we see something that's relevant here? We're going to check our PMS, CMS, SMVs, I don't care what you call it, but bottom line, do a neuro check. Okay? Check for pulse, check for sensory. Are they able to move? Get that sample history, and we kind of talked about this too with allergies, medications, what are they on, what's their past medical history. Last oral intake, I go through this and I'm like, all right, really the fact that they had eggs and bacon for breakfast this morning and they were in a car accident isn't really irrelevant unless they maybe have a blood sugar problem. The hospital may want to know that if they're going to take them to surgery and go ahead and intubate them, but for the most part, it is what it is for me. What were the events leading up? I was driving down the road, I got lightheaded and dizzy because I took my insulin this morning, but I forgot to eat breakfast, and so now I ran into the center median. What led up to my trauma at this point? Do your vital signs, get a good assessment. Remember, you want to get at least 2 sets of vital signs. Make sure that you're trending those vitals. Are they getting better or are they getting worse? Some of the areas that we miss for the most part, the back. Now when we get ready to put we don't put everybody on backboards anymore, but before we get up and we move them, we want to make sure we're assessing that back. Not only feeling or looking for any bleeding, but is there any bruising? In that flank area, did they get hurt? Do we have some bleed in the retroperitoneal area? What's the mouth look like? Okay, do we have any bleeding from the ears? And then our neuro exam. Making sure we're checking and doing a neuro exam before we move them and then after we move them. So here's our protocol. We talked about scene size up. We talked a little bit about initial assessment, airway, breathing, circulation. What does every traumatic arrest patient get in our system? Yep, bilateral needle decompressions, automatically. If we suspect a tension pneumo, they're going to go ahead and get a decompression on the affected side. Now, start with the focused exam here. This is our stable patient. We look at the mechanism of injury, we look at what kind of medications they're on, and then we'll start treating injuries, making sure obviously the airway. Consider the need for IV. It does not say start an IV. It says consider the need for it. Patient's hemodynamically stable. They've got a broken wrist. You want to go ahead and give fentanyl. Patient need an IV? No. No, you can go ahead and give fentanyl with the MAD device. You don't have to start that IV. Manage your pain appropriately. You know, it's a good idea before you move a patient to go ahead and give them pain management and then reassess them afterwards. Do they go ahead and need some more pain management? Do they need that second dose? Now I hear a lot of people stating that fentanyl really doesn't do a whole lot for pain. The MAD device doesn't provide the best pain relief. It does provide better pain relief if you're given an IV, but sometimes it's just easier before you move the patient to take the edge off with the MAD device. Once you get them in the ambulance, if the pain is still great, you could start an IV and go ahead and give them pain management that way. Now, if it's a rapid assessment, this is our sick patients. Obviously, we'll go ahead and manage C-spine appropriately. We'll go ahead and fix any life threats at that time. Do vital signs, pain scale, neuro exam, blood glucose. Package the patient and then IV fluids. We're going to give them an IV fluid bolus of 200 cc's. Titrate to desired patient response. What's the desired patient response? Well, a lot of times we say based on 90 systolic blood pressure, and that's for our medical. We're going to talk a little bit about something different with permissive hypotension, not raising the pressures up too much here in just a minute, but we don't have to change our protocols. It's to a desired patient response. What is appropriate for that patient right now? We can also go ahead and fix any other problems, do a detailed secondary exam, and then with these patients, they get sets of vitals once every 5 minutes because they're unstable. The other thing we ask you guys to do is to classify your trauma patients. Are they a level 1, level 2, or level 3 trauma patient? Now, our level 1s are based on vital signs. 2 systolic blood pressures less than 90. Or we can look at some of the injuries, meaning they have unstable pelvis, flailed chest segment, 2 proximal long bone injuries, depressed skull fracture. That's just a few as an example. These level 1 trauma patients go to the highest level trauma center within 25 minutes. You guys are very fortunate. You got one at St. Mary's and you got one at Evanston. Depending on where you're closer to, you can go to whichever. A lot of other places though, you know, they may actually have to make the decision. They're 10 minutes away from a level 2, but they're 20 minutes away from a level 1. They're going to go to the level 1 and bypass the level 2 if they have a category 1 patient. Now our category 2 patients, this is strictly based off a mechanism of injury. You have a car accident, the driver is killed. However, the passenger is out walking around when you get there, and they don't have a scratch on them. They say they're perfectly fine. But because of the mechanism of injury that possibly could have killed the driver, we're going to classify them as a level 2. The other things we look at is how far did they fall? How fast were they going when the accident occurred? And then we look at some comorbidity factors. Are they on an anticoagulant? Do they take Coumadin, Plavix, aspirin, those types of medications that might bump them up to a level 2? Now our category 2, I'm sorry. Category 2 patients can go to the closest trauma center. So if you're 8 minutes away from St. Francis, 5 minutes away from Evanston, you go to Evanston. Okay? We also have a category 3. This is our simple trauma. The 10-year-old boy playing soccer gets kicked in the shin and might have a fractured tibia. He can go to the closest ER. Somebody falls off their bike and breaks their wrist. Simple trauma. They can go to the closest emergency department. Now we do have a little caveat on the bottom here, and it says traumatic arrest, go to the closest trauma center. Not the level 1, the closest trauma center. And then any patients with no airway will go to the closest emergency department. For the most part, you guys should be able to get an airway. If you can't get an ET tube, you have a King tube. If you can't get a King tube for whatever reason, you have the ability to do a quick trach. The only time I would think that you might not be able to get an airway is if there's damage or an obstruction below the area, the cricothyroid membrane, where you would normally put the quick trach in, and you can't ventilate the person. This is our spinal immobilization flow chart. It's broken down pretty simple. Anybody who is high risk, has neurological signs and symptoms, they get full spinal immobilization. We haven't changed that. That's been pretty straightforward. Where people get confused is on the selective. With this, the person who says, oh, I have neck pain, but they're still turning their head, they're up walking around when you get there, you can put a seat collar on. Put them on your cot. Let them sit up if you want to. Remember, the definition of a padded backboard is your cot. So you can go ahead and use that appropriately. Those that don't need any signs of or any immobilization, the car accident, even though the mechanism might be great, but the patient's like, I have no neck pain, no back pain. I seem to be perfectly fine. I didn't hit my head. They don't need any immobilization.
Then,
Yeah.
has that been sent out?
Yep, we gave that to you guys last October. You need it again?
Yeah.
Let me just write myself a little quick note here so I make sure that we send it out to you guys.
Appreciate it.
Okay, I'll make sure that we get that, when I get back to the office, I will make sure that it gets sent out to you guys, okay? Not a problem. Not a problem. Okay. Does anybody have any questions on this though? Okay. Moving right along.
I'll answer.
Okay, what are we going to do for these trauma patients? Well, simple trauma patients, packaging is one of the big things we do for them, but splinting is the other. What kind of splints do you guys have here? Pro splints, air splints, trauma, or vacuum splints? You know what, really, that's all you really need. I mean, sure, the vacuum splints, the air splints are really nice, but sometimes they're hard to reassess after you put them on. You know, at least with the pro splints, I can take a look and I can see that extremity, see how it's doing. Not only is splinting going to help alleviate some of the pain, but maybe besides pain management, we can go ahead and put an ice pack on it. That'll also help. When we have our critical patients, we have a protocol for you called an abbreviated radio report to be able to quickly give the information to the hospital but still allow you to take care of your patient. When you decide to use the abbreviated radio report, one, you've got that critical patient, or two, maybe there's just one of you in the back of the ambulance and you've got a lot of stuff you've got to do, and you don't have a whole lot of time to be spending 5 minutes on the phone with them. Start off by saying, this is an abbreviated radio report. They're supposed to know at that point in time not to ask you 101 questions, but just take your information. Now, no more than 90 seconds of time. Really, honestly, it should be no more than like 15 to 20 seconds of time. Hi, this is Evanston. We are en route with a trauma patient. Patient was involved in a high-speed motor vehicle accident. This is a level 1 trauma. We will see you in 5 minutes. By telling them it's a level 1 trauma, that means my vital signs are probably less than 90. There's a lot of things we can safely assume at that point in time.
Category 1 trauma.
Oh God, I keep saying yes. Category 1. My mistake. Category 1. Not a level. Level 1 trauma center for a category 1. Just like with that multi-patient plan, you have a class 1 trauma, but a category 3 patient or something, you know, just trying to figure out. When we're transporting these patients, it's also really important to reevaluate them en route. Now you guys have short transport time, so you may get them packaged and you may get their interventions done. But try and at least reassess them once. Get a second set of vitals. Make sure you're assessing the interventions that you've done. If you splinted them and you move them to the ambulance, recheck their PMS, CMS, or SMVs. Make sure you go ahead and check the IV, check their vital signs. Is it beneficial? Flailed chest segments. Now, I'm going to give you a little bit of hint for one of the quiz questions. A flailed chest is 3 or more adjacent ribs with 2 or more broken in 2 or more places. So here's my 3 ribs that are broken, and they're broken in 2 places. We have a whole segment that's going to move differently, so don't get that one wrong today. Okay? When you go ahead and you breathe out, the segment goes outward. When you breathe in, the segment goes inward. How do we go ahead and fix that in the field? Some of you guys might remember when you used to use sandbags to use them. Some might have gone and said, we use an IV bag. Some say bulky dressing. Bottom line, we're going to use positive pressure ventilation to go ahead and fix the flailed chest segment. We're not going ahead and stabilizing the segment anymore. It's strictly positive pressure ventilation. Okay. Tension pneumo. There's a difference between a simple pneumo and a tension pneumo. Tensions, we're going to use a needle decompression. Simple, we're not going to do anything for. We're going to let it kind of ride out. We're going to monitor it. We're going to watch it. So what's the difference between the two? Well, our signs and symptoms for the most part. A simple, they may have shortness of breath, but their vital signs are still fine. Their blood pressure is good. They may have a little bit of elevated respiratory, maybe a little bit of elevated heart rate. But that right now is okay. They're not showing signs and symptoms of shock. Our tension pneumo, here they're getting maybe a little bit lower blood pressure, tachycardic, difficulty breathing. JVD and tracheal deviations are late signs for these patients. Might start to see narrowed pulse pressures, or their pulse itself becomes very diminished. Low oxygen saturations are also some of the other ones. So when we go ahead and we do a needle decompression, we look to go in that second intercostal space, in between the second and third rib. Now don't forget, the first rib here really hides underneath the clavicle. So as you're going ahead and you're counting your spaces, we're going to go mid-clavicular, all right? Do you guys have a special kit set aside or made up, or do you just grab an IV catheter out of the box and go ahead and use it that way? You have a special kit. I've seen a lot of departments, they think, well, I'll just grab that 14 gauge needle out of the IV kit. But they use only the 1.5 inches. The 1.5 inches are not long enough. You need to have at least the 2.5 inch catheters in order to be effective. Okay? You're going to go above that third rib, because that's underneath the rib is where all the nerves and the vessels are, so we're going to hopefully avoid them. We don't use a flapper valve anymore. We don't tear off the tip of our glove and put it through the needle anymore or attach a flapper valve. It's strictly we put the needle in. We leave it there. Or we pull the needle out, but we leave the catheter there. If we develop another tension pneumo, we'll go right to the right or left of it and we'll put another needle in at that point. Okay, anybody have any questions on trauma assessment? All right, fluid resuscitation. And I'm going to apologize to you because I'm going to skip probably a good portion of these slides. I can go through this whole 30 slides and tell you the sum up here in about 5 minutes overall. So
Go for it.
go for it, huh?
Prove it.
All right. All right. A lot of you guys remember shock as compensated shock, decompensated shock, and irreversible shock. Okay? They've actually changed it again. All this new changes is kind of getting overwhelming, I know, but they've classified the different types of shock. We start with a class 1, 750 mLs of fluid. This, to you guys, is still your compensating shock. We're not going to see a whole lot of change. The patient may appear a little bit anxious, but heart rate's going to be, or I'm sorry, blood pressure's going to be fine. They might be a little bit tacky, but not over 100 at this point. Respirations are still going to be fairly normal, 14 to 20. But we really don't know anything is going on. They're doing really well. Class 2, 750 to 1500 mLs of fluid. We're still anxious, but here's where we start to see a little bit of change in vital signs. Heart rate gets to be above 100. Respiratory rates 20 to 30. We actually, still at this point in time, will have a fairly normal blood pressure. But our skin parameters, a little bit cool, a little bit pale, diaphoretic maybe, at this point. Class 3, 1500 to 2000 cc's. They're very confused, they're anxious. A lot of you guys would probably consider this to be decompensated. Heart rate is up, respirations are up, blood pressure is starting to drop here. They're very pale, sweaty. Cap refill is greatly delayed at this point in time. And then finally, over 2,000 cc's of fluid. This is our irreversible, as a lot of you guys have known it. They're still confused. They're hypotensive. Heart rate's really up there, greater than 140. Respirations are up there. And, you know, he's got something in here about urinary output. That's fine. We're not going to worry about that pre-hospital. That's going to be, I think, something they can worry about at the hospital. What we get concerned about is how much fluid goes in needs to be the same amount that comes out for the most part. Remember with our age groups, young children, they compensate really well. They're doing fine. You think, okay, we're not having a problem. We're almost the way to the hospital. My child's going to be fine. And then bam, they fall off that cliff. They crash. And there's very little warning. They go basically from compensating to irreversible so quick. Elderly patients, their medications, like I said before, may blunt the signs and symptoms of shock. Blood pressure medications, beta blocker, heart medications. You might not see changes in their vital signs. So, fluid resuscitation on trauma victims. We said earlier on these patients, titrate blood pressure to a desired patient response. Now, in the past, a lot of you guys remember 2 large bore IVs, run them wide open, and we would flood these patients with fluid. We've obviously realized that's not the way to go. We don't want to do this to the patients. We have to be very careful on the amount of fluid that we give a trauma victim for various reasons. First of all, does oxygen, or does normal saline carry oxygen? No, it doesn't. So we've got a patient who maybe is a class 3. They're starting to decompensate. We fill them full of fluid. These patients become hypooxemic. Now, do you guys know, does your monitors or your automated blood pressures give you a MAP reading, a mean arterial pressure reading? All right. A lot of people don't even know what that is, I'll be honest with you, but it's systolic blood pressure plus 2 times the diastolic divided by 3. Do some math in the back of the ambulance, right? But really what it's telling us is, do those end organs perfuse? Are we perfusing the heart, the brain, the lungs, the liver, the kidneys? Now, normal MAP readings are somewhere between 80 and 120. But when we get to that MAP reading that's less than 60 or right around 60, we know that our end organs are not perfusing at that point in time. And that can be a bad thing because obviously that can lead to renal failure for some of these patients. So by going ahead and giving them a whole bunch of fluid when they don't have a lot of blood in their bodies, you're going to flood the system. It's not going to be able to carry oxygen to those end organs for these patients. The other thing is by flooding the blood itself, the platelets, they're not going to be able to go ahead and clot at this point in time. There's a doctor up at Frater that carries a tube of blood around in his pocket, and every paramedic that brings him a trauma, he shows him this tube of blood, and it hasn't clotted in years, just because it has so much normal saline in it. And then the final thing we worry about is clot popping. As the body goes ahead and has a damaged vessel, it sends certain chemicals to go ahead and start to provide a mesh over it. It starts to heal that vessel or clot that vessel so that it stops bleeding. And it's doing real well at that lower pressure. But the minute we start raising pressures up, it can pop that clot off or break that clot open. And therefore they start bleeding again. So what pressure do we go ahead and go to when we're giving fluid boluses? They're actually looking at about 85 systolic. We don't want to try taking them up to 90 to 100 systolic. Just a single IV, give them 200 cc fluid boluses, try and get them somewhere between 80 and 85 systolic. That patient will do much better. Now, if you do have the internal bleeding or any bleeding stop, you can raise the pressure up just a little bit more, but not until after we get the pressures stopped. So we'll cause hemodilution by overflowing, we'll decrease the oxygen carrying capability and decrease clotting factors if we go ahead and give these patients too much fluid. Other complications of too much fluid, I was almost there, yes. We could send these patients into adult respiratory distress syndrome. They can end up with sepsis, different types of coagulation problems, and ultimately renal failure. See, I did it in 5 minutes, right? Here's your map reading, your nice little, for those of you guys who want the formula to work in the back of the ambulance. This here, map of 50, it's got to be a typo. It should be a map of nothing less than 60. Otherwise, we're not going to have end organs perfusing. So, does anybody have any questions about permissive hypotension? Bottom line, when you've got a patient who's bleeding out, just be very careful with your fluid administration. Keep the systolic right around 80 to 85. Don't give them any more fluids than that, because like I said, you don't want to change that blood to Kool-Aid. Kind of very simple terms. Okay? Last month, did you guys, I pulled up the pulse form. You guys got that information? Does anybody have any questions on the pulse form itself? This is actually, I'll be honest with you, this changed in 2011 or 12. This is the new DNR form. And like I said, they're either going to click A, box attempted or not attempted. You guys are only going to worry about box A and B. Box A is if they're pulseless and non-breathing. Box B is if they're basically circling the drain, I guess is the best way to put it. Meaning they still have a heart rate, they still may be breathing. How are you going to treat them until they actually become pulseless and non-breathing? Do they get full treatment, selective treatment, or only comfort measures? And that's what this paragraph is saying here. And that's what they're looking at. C and D, or C, is for the hospital. Now remember, 5 things have to be on this form in order for it to be legal. The patient's signature, a witness signature, the doctor's printed name, and the doctor's signature and a date. You have to have all 5 of those in order for this form to be valid. Okay? Yeah.
Does it have to be the original?
Nope. Nope. You can have photocopies. It doesn't have to be on that pretty salmon colored paper anymore.
No stamp or nothing?
Nope, no stamp, nothing. The signatures of the doctor have to be original. Okay, you can, it can't be like a stamped signature with a photocopy. You can have a original.
Signatures, huh?
Yes. I don't know how you're gonna, some stamps you can tell it's a stamp when you make a copy, others you can't, so it's just. There's only about 4 or 5 states that have not switched over to this form, so should be seeing them all over. I understand the whole point of someone is getting ready to pass on, or they're having difficulty breathing, but to me this is a lot of very gray information for you guys to have to try and wade through with a patient that may or may not be dying. They talk about, well, you can use CPAP, but you can't intubate. You can use positive pressures. You can use vasopressors and antibiotics, but you can't use, this one. You can only use pain management. Don't take them to the hospital. It gets to be a little bit overwhelming. Bottom line, just contact medical control if you have any questions on it. Let them make the decision, because sometimes it's not very clear at all. And you might have the guy who checks, do not attempt resuscitation, but give me selective treatment if I'm still alive and I'm in the process of dying. Sometimes it may not even make sense. So, backside is just strictly information. Who's their power of attorney? Where are their living wills documented? Remember, we don't honor living wills. We only honor this form. Anybody have any questions on the pulse form? Okay. Have you guys been informed about the CE requirement changes?
100 hours now?
Well, the 100 hours, that was back in 2014. They changed that. St. Francis did drop down to the 100 hours, but the type of hours that you now need. All right, the State Education Committee, we actually have a continuing education subcommittee. And what we were finding out throughout the state, that a lot of departments were using hazmat, dive rescue, confined space rescue, high angle rescue, hazmat, and they would never have a cardiac class or never have an OB or a PEDS class in their whole 4 years to renew their license. You guys are going, yeah, so your point. So we actually decided that it would be a good idea to switch to something very similar to what the National Registry does, which is have so many hours in each category. Now, as long as you guys attend all 8 mandatory trainings that St. Francis puts on here, you will meet the requirements for relicensure, getting the correct number of hours in each category. So like preparatory, 8 hours, airways 12, patient assessments 8, traumas 12, cardiac 6, medicals 20, special consideration, which is neonate peds, gynecology, OB, 16, 4 for geriatrics, 4 for operations, and that totals up to be 100 hours. Now, this is just a list of all the different ways you can get it. St. Francis, you have to attend, if you are primary here, you have to attend all 8 modules. Okay, that's their requirements here. If you're secondary and primary somewhere else, you can use these other methods to go ahead and obtain. So if you take an ACLS class that's 16 hours, you can go ahead and apply that ACLS class to your 16 hours of cardiac. Okay. But this is published on the IDPH website. If you want to know, Lisa does have a copy. Yeah, we approved it through the State Education Committee, and the AMS Advisory Council ended up finally signing it into law. So this is in effect as of now. What about those that are going to be renewing in the next year or something like that? We'll only take a portion for that year of what you're going to need. So, we'll prorate things. But anybody have any questions on that?
So our ACLS and our PALs here are useless towards recertifying?
Absolutely, it can. Absolutely.
Useless?
Yes, they're useless.
Useless or
Useless. I mean, no, the class is very good, don't get me wrong. But it's useless for your relicensure because you've got to sit through all 8 modules anyway.
Right.
But just think how much more smart you're going to be by having ACLS. Better rounded paramedic, right?
You take ACLS, you do this cardiology module.
Well, no, because Region 10, or St. Francis says you have to have all 8 modules. You know, and that's, I mean, each system is different. Now, like you go to Vista's system, they just require 30 hours every year. They don't care how you get it. They do 10 CEs a year, but you don't require you to attend those CEs. If you take ACLS, that counts as part of your 38 year. So they, you know, St. Francis just makes you have the modules here, the 8 modules. So that's their thing.
That makes sense.
All right, anybody have any other questions on this? If you need this, Chief Collins should have this. You can ask him, or you can go to IDPH's website to grab a copy. Okay. Moving right along. Crush injuries and burns. Johanna, our trauma director, or trauma coordinator, she put this presentation together along with Adam. We're going to kind of discuss a little bit about crush injuries versus crush syndrome and understanding how you can end up with some of these. Now, most of us realize that we can end up with crush injuries, being buried under a building, some of these mass type of incidents. But we can have very little things too that we could see crush injury. One of you guys gets really tanked on Friday night and you pass out laying on your arm on the hardwood floor. You can develop crush injury in that arm just from having a little bit too much to drink and passing out. Even patients that are in a coma and they have prolonged muscle compression might end up some kind of injury. Now, let's say for example, you have a gentleman who a car falls on him. He was sliding out from underneath the car from doing some work, and all of a sudden the car fell on him at the level of the hips area. When you guys get on scene, some of the very first signs and things that you want to do is get that car off of him. But you need to know some more important information before you start pulling him out. How long has he been underneath that car? How long has he been trapped? Because if he's been trapped for really longer than 20 minutes to a half hour, you want to leave him there until you have the correct components in place. What do I mean by the correct components? Well, some of the things, obviously, we know that if we lift this car right off of him after he's been compressed for a while, one, his blood pressure is going to drop. You know, because right now everything's just been circulating in this area. The other thing is, though, since stuff hasn't been circulating in the lower extremities, it's built up a lot of toxins. It's built up lactic acid, uric acid, potassium. And the minute you start circulating things around again, all those toxins and waste are going to head to the heart. And then you're going to see arrhythmias. And that's how patients end up dying. So you really have to figure out, what do I need in place before I go ahead and I remove this patient from being compressed. We can also see this with suspension injuries. Do you guys, anybody here do high angle rescue? Okay. Even at that point, for some reason, you're dangling up in the air for a long period of time. You got to make sure that you're moving your legs. Remember, your muscles in your lower extremities are also beneficial in helping circulate your blood. It's not just your heart that's doing all the work to circulate the blood all the way down to your toes. It's your muscles. By walking, by moving around, the muscles contract and those blood vessels get compressed in there and help send blood back to the heart. Which is why a lot of times you're sitting on a plane for 14, 15 hours and you're not moving your legs, blood can pool. You can end up with emboli, DVTs that might actually occur. So, here we look at injury to the muscles can be caused by one, vascular compromise, direct force, direct pressure. Remember those three. You might see them a little bit later on, okay? That's how we can end up having damage to the muscles. Now, after 4 to 6 hours of being compressed, sure, it's irreversible. But we really start looking at the point that after about 20 minutes to 30 minutes, we can start to see toxins build up within the area. This here is actually a fasciotomy. You've got that hard casing around each muscle, okay, the fascia. And it's kind of like the vault of the cranium. You know, the brain goes ahead and swells. The skull itself does not move. So when we see this happen, we start to see a shift in the brain, which causes damage. Well, and a muscle group gets injured. You go ahead and you have swelling to that area. The fascia itself is not going to budge. And so therefore, it starts to put compression on the blood vessels, the muscle itself, the nerve endings. And when this happens, depending on how long that compression lasts, depends whether or not that muscle will actually survive, or if that muscle will start breaking down and we'll have something called rhabdomyolysis actually occur. Now, he's got some big terms like anaerobic metabolism, reduces ATP production. That's all fine and dandy. Not going to help us really that much in the field. But bottom line, what we need to know is that if that muscle group is compressed for a long period of time, it's going to do damage. Someone who goes into rhabdomyolysis from the breakdown of the muscle, we can see them end up in renal failure. And that is going to be an incident that you guys might end up seeing. The fact that we have all this other stuff going on, that's fine. Toxins begin to build up in the muscle groups themselves. The cells are going to swell in response to the injury. And that's going to increase the pressure in that compartment itself. And ultimately, they need to do the fasciotomy. They got to break open that fascia and allow the muscle to basically be able to breathe or swell so that it doesn't put further damage on it. Here, we also see capillary permeability that happens with these injuries. So plasma from the blood vessels starts to seep out of the capillaries themselves into the third space, into those cells. Those cells swell. We actually will see large toxin loads. So we'll start to see the potassium leak out of the cells, which we know that when a patient has high potassium levels, we can see cardiac arrhythmias. Patients hyperkalemia or hypocalcemia, they'll end up having muscle weakness or possibly paralysis. We'll have an increase in myoglobin in our systemic circulation, which ultimately can cause the kidneys to not be able to filter out the waste, which will lead to kidney failure or kidney failure. So rhabdomyolysis is basically the muscles themselves, the skeletal muscles themselves, starting to break down. Okay. Whoops. Some of the things, crush syndrome. This is actually traumatic rhabdomyolysis causing, some renal failure. Muscle reperfusion involvement of the muscle mass group itself. And we talk about the prolonged compression for 4 to 6 hours. That's when we start to see usually the rhabdomyolysis. That's the irreversible area. But we can still see toxins build up fairly quickly. With these patients, crush injuries can cause renal failure, multiple organ dysfunction, ultimately sepsis. Pulmonary-wise, it can lead to having acute respiratory distress syndrome. DIC, which is disseminated intravascular coagulopathy, meaning the patient starts bleeding from almost every orifice of their body at that point. The body recognizes little clots within the vascular and it sends out chemicals to try and break up those clots. And in the process, the patient starts bleeding out. But the big thing is the cardiac electrolyte imbalances, arrhythmias. We know that a normal potassium is 3.5 to 5. We can see this on our monitor. If we put a monitor on someone, we see tall peak T waves. We know that if someone's potassium gets up to be about 7, the SA node stops working. We start to see the P wave disappear. The QRS complex gets wider. And ultimately, that patient is going to end up in cardiac arrest towards SODS or VFib or VTAC very shortly. So what are we going to do for these patients? So let's go back to our guy that's trapped underneath the car, okay?